Welcome to True Health Tuesday, and the truth will set you free. Okay, we're going to be changing up a few things. We're going to be taking all of our vaccine videos off of YouTube and putting them on BitChute. And we're going to be doing this in a pretty rapid fashion to keep us on. But honestly, I'm kind of excited because the way society is changing rapidly now, I don't think that we're going to be kicked off of YouTube. Not good. So we're going to go back and do a series of videos on how to take care of yourself, like how to regenerate. We're going to talk about reversing arthritis. We're going to talk about pelvic insufficiencies, hiatal hernias, inflammatory bowel disorders. I know, fun stuff. No, inflammatory bowel. Okay. So anything, we're going to talk about reversing degeneration, reversing arthritis, restoring knees, restoring meniscus. But also too, we got to get the work out of the way. This is in 2 weeks. Now, we had a contest in our office where we gave away like 10 or 15 tickets, but Bergman, 20 is the code. It's February 14th to 16th. I mean, Robert Kennedy's going to be there. You can save 20%, just type in Extreme Health Academy. You get this Bergman 14, you get 2 weeks free. Just get on there and look at the information for 2 weeks. It's incredible. There's multiple doctors from around the world. It's just brilliant. And we're down to 5 cabins left. Even though it's like 2 months away, go to drjohnbergman.com and sign up there, or BSG Meetings, LLC. 12 hours of continuing ed credit. Okay, do you know what most people heard with that? Deductible. Okay, so we're going to get it. So how did I get into knees? Well, I've had 2 for 60 years. Well, it'll be 60 years in a month and a half. Or when I was 22, I was doing some work because I was a contractor and I was on top of a second floor doing some woodwork. And the ladder kicked out from underneath, slammed onto the sidewalk, and I shattered my right kneecap into multiple pieces. And they did, since the patella healed up funky, they ended up grinding it off, and it was a miracle. I go from hurting, walking with a limp, to actually walking normally. I mean, just an amazing surgery. Then a few years later, I'm walking across the street and I happen to get hit by a car. Now, you know what my kid says? Okay, they said, "Dad, didn't you look both ways?" Okay, did I have guilt or guilt? Okay, and so there I had both my tibias, the bottom bone, fractured lengthways. I fractured my sternum, fractured my skull, I bruised my heart and liver. And it was interesting because at the time I didn't know anatomy and physiology. And I said, "How did you know I bruised my heart and liver?" And they said, "Well, when an organ is damaged, enzymes in that organ are released into the bloodstream so they could tell that something was damaged. And they can actually identify the organ." I just thought that was cool. And my front teeth were knocked out. So when it comes to this, except the surgery was amazing. I mean, here they take a guy that's laying on the ground, concussed, bleeding. It was not pretty. They bring him back to life, and they're giving me medications and surgery. Now, at the same time, I had just put an x-ray lab in for a chiropractor. And so I'm going in, and the chiropractor's adjusting me while I'm in the wheelchair with my legs in casts. And he's saying, "Nah, Bergman, you're going to be fine. Your body is self-healing, self-regulating. Okay, your knees are going to regenerate." And I go to the medical doctors and they're saying, "No problem. We're going to do a few operations on it. Your knees are always going to be distorted. You're never going to be able to walk correctly. And we can replace them in just a few years." Okay. And I'm going, wait a second. These are 2 doctors that I really respect. How can I get such different information? So I go in, and I was so excited to have an operation because my knees were really, really hurting. And the first time I had it 8 years before when I fell off a building, it was a miracle. And so I go in there and they ground it down and it felt kind of funky. And in fact, it felt unstable and it still hurt a little bit. And so what did the doctor say? No problem. One more operation and, we just had to take a little bit off. And so they do another operation on the other knee and it felt kind of unstable too. And so then they did another operation. So there's going to be 4 total. And it didn't feel better. It felt less stable. Now, common sense, is that really strong today or very, very rare? Well, this is back in 1990, and it was still strong back then. So I got to thinking, my knees are feeling less and less stable. They feel less and less strong. Every time they do an operation, are they putting stuff in or taking stuff out? They're taking stuff out. And so that totally changed it. And then since it was harder to work, and it's almost like, thank you God for destabilizing some of my knees, because otherwise I'd probably still be a contractor. And so I went into chiropractic and turned out I had a real knack for anatomy. And so after dissecting, dozens and dozens of bodies and looking at the knees and learning about arthritic changes, learning about tissue regeneration, it was amazing. And so I found out that the knee actually can regenerate. And it regenerates really, really well. But first, we got to look at the structures. I mean, if you look at the blue areas over there, we have bursa sacs everywhere. And you figure a muscle crosses a joint via a tendon. And that could be a source of friction. So what happens is, the way the body is built, you have bursa sacs surrounding and cushioning this. And this is vital. Now, do you think the fluid in a bursa sac, what's it called? Bursa fluid. Bursa fluid, that's so good. Okay, now that's a superfiltrated blood, but here's the problem. If you have a compromised blood supply or nerve supply, now people will hear bursitis in the shoulder or arm or wrist, okay? If your head is forward, that's choking off the blood supply, that's decreasing the blood flow to those joints, and that's decreasing the superfiltrated blood that fills up the synovial sac around the joint and also fills up the bursa fluid. So we have to have healthy blood and healthy blood supply in order to have those bursa sacs filled with fluid. Now, the knee joint is basically 2 bones coming together surrounded by a capsule. And that capsule, again, is the synovial membrane, but it's a superfiltrated blood. And this is also why people that have unhealthy blood, like type 2 diabetics, the blood is a little thick, or chronic stress, it can't really filter out through that membrane. And so this is where knees will start to swell. And sure enough, with the knee traumas I had, the knee would swell up. And so I'd go there limping like crazy, and the doctor would shove a needle in it and draw out fluid. And it was really weird looking fluid. It was like a little red, a little clear. It was kind of neat. Okay, but then I'm thinking, wait a second. So if you have a knee swelling, does that mean you have a problem with blood flowing in or blood flowing out? Blood flowing out, because it's blowing up. It's like a balloon. So then I got to thinking, well, wait a second. So the synovial fluid is always being produced. It's going in, going out, going in, going out. And if the valves that are allowing that synovial fluid to be reabsorbed in the tissue are clogged, then it starts to swell up. Okay, does that make sense? And it turns out that that's true. So when we're looking at this, the bursa sacs are all around it. But if we have compromised blood supply, nerve supply, or unhealthy blood, then the joint won't be functioning correctly. Does that make sense? Now this guy, at the time these x-rays were taken, he was 66. And what you'll see 2 sets of knees, before and after. And you'll see there's very, very subtle changes. But the guy went from massive pain, limping, to no pain on the x-rays on the right. And you might be thinking, well, wait a second, there's not a big difference there. That's because knee pain isn't just from the knee. You got to look at the entire structure involved. You got to look at the blood supply, the nerve supply, and that's what we're going to be going over. Now, you also might see a little tiny round circle thing in there. That's actually the patella. Now, the patellar kneecap should be in the middle of the knee, but a lot of times you're going to see the legs aren't straight. There might be a little internal or external rotation. So that can you might think that the patella is off a little bit. So you have to look where the fibula is, which is the small bone on the outside of the knee. That's a non-weight bearing bone. And so you have to look at that to gauge it. So when you're looking, full pain relief and stuff, but there's still compression. Now we get into the structure. When you look at meniscus in a real live dead person. Okay, so real live dead person, you get that, right? Okay, because it made sense in my brain before I said it. Okay, so you're looking at a cadaver. It's like thick Tupperware. Okay, and it feels kind of like that. Now it has two parts to it. And you'll see that this is the tibia, or the lower leg on the bottom. This is the flat part where the femur rests on top. Now it pivots on the outside. That's why the outside there, or the left-hand side of that tibia plateau, is like a circle. Now you have a C-shaped part on the inside of the knee, which is where it pivots. So the knee joint, if this is the outside, it doesn't bend like a hinge. It bends like a screw. Okay? So that means the medial part, or the inside part of the knee, is completely different. Okay, it's not a hinge. So this thing is going to guide and slide. And in fact, when a lot of injuries occur where there's an impact from the outside in, it's called a terrible triad of Donahue, where the medial collateral ligament breaks, the medial meniscus breaks, and the anterior cruciate ligament. And that's coming from a clipping injury or an outside injury. And that's something that's really, really painful. But the medial meniscus, and that's the guide. So it's like a Tupperware guide that guides that femur in, so it pivots and glides, pivots and glides. Now, when you're walking, let's say you take a step, bam, that joint opens up because your leg is swinging in the air. So that's actually creating a negative pressure. When you stand on it, you're creating a positive pressure. So the way you're designed is amazing. The more you use it, the more blood flow flows in there, blood flow flows out, and it turns out that if you use it, it gets better and healthier. So this delusional aspect of a lot of doctors saying, well, it's just worn out. You're 45. Okay, none of this is true. One of our patients, he's got 5 Super Bowl rings. He's, I think, 61 now. And the guy is tough as nails, works out every day, and he was a running back, I think. And these guys get beat up a lot. And I'm looking at his knees, perfect. Hips, perfect. And we're talking multiple traumas. But what happened? Did he have good blood supply, nerve supply, and healthy biomechanics? Did he use them a lot? Yeah, he still does. He runs every day. So now, this is where we get in the delusional world. When you look, you'll see that little red line coming outside of the meniscus. That's called the vascularized zone. That's where blood vessels are. Now, the white zone is under a compressive force loading. Now, if you put a blood vessel under a force loading, is there going to be good blood flow or poor blood flow? Poor blood flow. So that would be weird. You stand up straight, you're shutting blood supply off to the meniscus. That would be a piss poor design. So what happens is we have an avascular area that's under a compressive force loading. Now that's not acellular, it's just avascular. It doesn't have the blood vessels. So those cells in there get their nutrients from the synovial fluid, which is the superfiltrated blood. Okay, so does this make sense? So every time you walk, you create a negative pressure and a positive pressure, negative pressure and positive pressure, causing an increase in synovial fluid production. You have the outside of the synovial or the meniscus that has a blood flow, okay, that is going to be repaired because you're going to find out, and think of this. So if you have the femur coming down and the meniscus holding it in place, and you have a compressive force loading, and you have an injury to that, is it going to injure the part that it's resting on or the side part? It's going to injure the side part. Okay, and again, we're just talking common sense. Okay, and I'm going to show you some torn meniscus and how it heals, which is really cool because the outside, since it's vascular, it heals faster. Okay, makes sense so far? Now, because there's still doctors out there that are not up on the latest literature. Yes, Christine, that's called politically correct. Okay, so the Journal of Clinical Orthopedic Trauma, Meniscal Repair and Regeneration. Historically, the meniscus were considered to be functionless vestigial structure that one should entirely remove once damaged. No, seriously, there's still doctors that think that, by the way. Okay, 1948, Fairbanks reported degenerative changes were observed after mastectomy, suggesting that the changes were due to loss of the weight-bearing function of meniscus. So meniscus can actually hold and guide the femur in place. And addressing the importance of meniscus as a joint stabilizer and shock absorber in the knee and meniscal preservation has been recognized to be essential to retention of normal knee biomechanics. And I'm reading this and I'm going, okay, 2018, great, they're just coming up with this. I got my operations back in the mid 80s and in the early 90s. Wouldn't you think, okay, now just knowing that in that, 20-year span or 18-year span, that wow, looks like just ripping up meniscus, isn't it really good for the knee? What do you think is going to happen in another 40 years? We're going to see. Okay, however, mastectomy to remove the damaged, unstable portion of the meniscus has still been the gold standards of surgical treatment for most meniscal tears, since there has not been effective therapeutic methods developed for such tears. And I'm going to show you why there hasn't been therapeutic methods developed by the chemical industry. The medical industry. The chemical industry. Well, you're right. I was right both ways. Okay. So now let's look at it. And just to reinforce this, the tibia's here, femur comes down on top, tibia has this little guide in it, okay? And the outside edge is vascular, okay? The vascular, 80% composition of dry weight is type 1 collagen. The avascular, 40% is type 1, 60% is type 2. Okay, so you start looking at it, well, they're two totally different compositions of material. Cells of the meniscus require loading to maintain the integrity of the meniscus. As the loss of loading can lead to depression of catabolic genes and potential induction of tissue atrophy. Wait a second. Cells of the menisci require loading to maintain the integrity of the meniscus. So that means, okay, get this, you have to use it to have it heal. Going, wow! Okay, then loss of loading can lead to depression, and catabolic means breakdown, and induction of atrophy. So it turns out that if you immobilize it, if you alter your mechanics, or you just don't bend it because it hurts, you're going to start to damage the tissue itself. And so now, this is a Canadian gal, no, different one. And we're looking at a before and after. Okay, now one of the key things here is you're going to see the knee joints are in pretty good shape. But her knees were killing her. They were in agony. Okay, and now when you look at the knee, you can't look at just the knee. Because what we have is we've got a foot that has altered biomechanics. We're going to have a calf muscle, and the calf muscle has a pump in it called the soleus. We're going to look at patellar tracking. And also, the nerves that supply that area are called dermatomes. And when we're looking at the pelvis there, you can see the first spine, the one before that was 9 degrees, angles up and then over and then up again. The middle of the lumbar is the third lumbar, and that's the nerve that actually supplies this. And in fact, the fourth lumbar goes below the knee, L3 goes to the knee, L2 goes above the knee. So we're looking at the lumbar supplies that whole leg area. So if you compromise a nerve to an area that it supplies, guess what? That area it supplies doesn't have appropriate function and isn't healthy. Anyone want to say, duh? Okay, so we're just talking basic common sense. Here's the challenge though. One of the biggest areas of her pain was on the pelvis, because if you're walking with a knee injury, are you walking just beautiful or are you walking with a little bit of a limp? Okay, so that limp is going to cause a destabilization. Plus, if you look at the gluteal region, okay, of human beings, if you take say the right knee, and you have damage on the knee, or is anyone willing for me to crush their like right toe? Just no, Christine, I appreciate the going for it. No, I'm not going to crush your right toe. Okay, but imagine if you hurt your right toe, foot, knee, whatever, your whole weight is going to shift to the left side, right? So that means that if you just stand here and lift your right leg right now, my left glute is firing off to maintain the integrity. So if you have any problem on one side, you're going to have the contralateral medial gluteus fire off. And anytime I say, if you hear music, it's just coming from my soul. Okay, so we've got before and after. So the key is to correct the problem. Okay, does that make sense? So when you're looking at the X-ray on the left, we've got altered biomechanics of the lumbar. We've got altered nerve supply going down there. We have pelvic instability because we're looking at a whitening of the sacroiliac joint, and then we're looking at correction of that. So you're not looking at the symptom. The symptom's the red flashing light. And it's interesting because looking at her symptoms, low back pain, neck pain, headaches, fatigue, wrist pain, digestion happened to be bloating and constipation, shoulder, hip, knee, ankle, foot, tension across the shoulders, numbness and tingling, difficulty sleeping, and anxiety. Okay? If I had you sit on a tack, you would hurt. If you sat on a tack or had a painful stimulus for 20 years, you would have every one of these symptoms because this puts you in a stress state. Does that make sense? So to treat just a joint injury as a joint injury is foolish. This is the dermatome map. Okay, and the cool thing is when I'm talking to students, I'll say the best thing you can do is listen to your patients because they'll tell you where it's coming from. Because people will go, Doc, man, it's amazing. It hurts right here. And I'll go, that's L2. By God, I know that one. No, it hurts right here. The T12. We can fix that one. Because the area of skin supplied by a specific nerve root, if that nerve root is damaged, the person feels the symptoms along that nerve root. And that just means that there's a disc injury or anything else. And then don't let disc injuries scare you because all it is a ligament that's damaged. Discs are alive just like meniscus is alive. And disc can regenerate. And you'll see it over and over and over. In fact, let me show you. Before and after. This happened to be the mom of the first Canadian. Yeah, she was also Canadian. Okay, so and we're looking at a significant lateral deviation before, and we're looking at a nice correction afterwards. But she also had knee symptoms. And what you're looking, if you can look closely at the knees, you got two knees coming down, but there's not the same angle on it. Okay, there's a little bit different. And that's because she's had altered biomechanics. So you have to restore everything. If somebody comes in with a knee, and we're just think common sense in the whole world here. If somebody has a knee injury for longer than a day, do you think that they've been walking crooked? Okay, if they've had it for a year, do you think they've been walking crooked? If they've had it for 20 years, do you think they're going to be walking crooked? So is that going to alter the biomechanics of the foot, the pelvis, the knee, the shoulder, the neck, everything? So they call it holistic. You're going to look at the whole body. If anybody isn't looking at the whole body, they're wholly, okay? They're missing the big picture. It doesn't make any sense. I mean, what are you going to do? Fix her lumbar spine or leave the lumbar like this and give her a drug or a shot to the knee? No, that doesn't make any sense. That's foolishness. Now, again, Journal of Clinical Orthopedic Trauma, loss of appropriate loading after an injury can thus contribute to the progressive deterioration of the injured tissue. Think of that. What they're just saying is if you've had damage, your body is going to shift its force loading to take the pressure off. If you don't restore the normal force loading, it's going to further damage the tissue. The circumferential orientation creates biomechanically optimal resistance to hoop stresses, resulting from the displacement of the meniscus from the tibial plateau during normal weight bearing. Now, if I said this in English, you would say, damn, that makes sense. What they're saying here is you've got the tibial plateau that has that round thing there that guides the medial aspect of it. You got this totally round thing that guides the lateral, so it pivots and glides. And they're saying if you have loss of the normal biomechanics, you can damage the things that hold it while it's working. Okay. I don't know why they had to word it so complicated, but that's pretty much it. If you have altered mechanics, that's going to damage the structures involved. Now, this is interesting. This guy's 77 years old, but see the white lines on the leg? Okay, that's literally plaquing of the arteries. This guy had one of the most horrible toxic jobs ever. But we're looking at arterial plaquing. Now, it's interesting because his right knee is damaged and his left hip is damaged. Okay, and there's arterial plaquing. Because remember, what is a joint? Two bones coming together, surrounded by a synovial membrane, and the superfiltrated blood gets in there to nourish and get the joints nutrified or nourished. And so when you look at this, what came first, the knee injury or the hip injury? If you have damage on the right knee, the entire weight is going to shift over to the pelvis. But when we're looking at the lumbar spine there, we're looking at a massive lateral deviation. You know, just for the heck of it, he's got a knee problem and a hip problem. Anyone want to take a look at his rib cage, thorax, cervical? Maybe look at the biomechanics of the foot. How about we ask how many bowel movements a day he has, how he's sleeping, okay, what his nutrients are like. Anybody? See what I mean? Looking at the whole body. You can't look at just the knee. That's craziness. This is hugely important. This is what you're going to see a lot of times. You're going to see a pretty decent space coming along, but then it's a little bit close. Now, the doctors will actually, it's not purposely ignorant, well, or maybe it is, I don't know. They're going to say, oh, it's bone on bone. Okay, it's not, because the tibia plateau isn't flat, it's at an angle. Now, you can see a space in between my hands, yes? Okay, can you see the space? No, if you could see through this, you'd see the bottom of my hand or a bone or anything else, but the space could still be there because we're looking at a three-dimensional structure in 2 dimensions. So when the doctors say, well, it's bone on bone, that would be very, very doubtful. And even if it is, even if there's a thin film of cartilage, okay, it can regenerate because cartilage is alive. So just to reinforce, you've got the inside part of the knee, the big round C, the outside part, the little circle. And so we got to look at this. Now, here's a gal from West Virginia. Okay, now, really sweet gal, but we're looking, the knee joints are actually pretty good. Okay, and knee pain was one of her biggest complaints. But we're also looking, oh my gosh, that's a reverse curve in the neck. Now, why would I take a picture of a neck when someone comes in with knee pain? Because it's connected. So she's got a reverse curve. The head, which weighs around 12 to 15 pounds, is forward for about 3 inches. And all you got to do, even if you're sitting or standing, put your head forward. Does that flatten out the curve in your low back? Absolutely. Plus, we're looking at the full spine here. We're seeing the entire torso shifted off. If you've had a torso shifted off because, I don't know, maybe you rode a horse and you got off incorrectly. Bam! Okay, so that's going to, if you put your torso like this, is that going to change the force loading on the pelvis and the hips and everything? You know, again, it's just common sense. So to correct this, do we need to correct the neck, correct the sleep patterns, clean up the blood, look at the biomechanics of the foot, the calf, everything? Absolutely, just common sense. Because when we look at any pain anywhere, we have this automatic nervous system called the autonomics. One part keeps you alive under stress. That means 100% of the time, if you have physical, chemical, or emotional stress, and when we're talking knee pain, that's a big pain. That's a joint that hurts when it hurts. And so this is going to put your body in the stress state. So that means heart rate's going to be elevated, blood sugar is going to be elevated, blood pressure is going to be elevated, blood supply to the gut's going to be decreased, Immune system is going to be decreased. So if you have this consistent sympathetic dominant or stress state, day in, week in, okay, year out, what's the person going to be misdiagnosed with? Anxiety, decreased blood supply to the gut, low serotonin production, get inflammatory bowel disorders, sleep disorders. And then with the sleep disorders and gut disorders, oh my gosh, you got anxiety, stress, or depression. We got to give you some drugs. Okay, and aside from which, what's given for pain? Anybody, what's a common drug? Advil, Motrin, Aleve? Okay, yeah, non-steroidal anti-inflammatories, which destroy the building block of cartilage. So when these doctors say, well, meniscus doesn't regrow, no kidding, because they're given a drug that stops the regeneration of cartilage, but it makes you comfortable. Okay, so again, 76-year-old gal, and we're looking at her lumbar. It's okay, you can let the cell phones go, I'll just talk louder. Okay, we're looking at her full, she's standing up straight, significant lateral deviation. The knees are pretty good. Okay, there's a little abnormal patellar tracking, little internal rotation, there's a little swelling of the sacroiliac joint. No, I can talk over it. Okay, and so when you're looking at that damage, it just makes sense. But let's look at the symptoms. I mean, 76 years old, I mean, you should be playing racquetball, you should be going windsurfing. We got a guy in his early 90s who's actually, what do they call it, sailboard, or, where they have the what is it called? No, this is the old school, okay, where they had a windsurfing. Yeah, windsurfing, okay. And the guy is cool. He says he only goes when the wind's perfect, and he goes about once a month. But this, dizziness, why? You've got three things that govern balance. One of them is the inflammation coming up the dorsal columns. Headaches, fatigue, digestive problems. What do you think it is? Diarrhea, constipation, fluid, bloating, all of those. Then you're looking at anxiety. Why? Because this person's been under chronic stress for forever. Difficulty in sleeping problems. And you are thinking right now, wow, that's a sympathetic dominant state. This person must have been hurting for years. So now, in what world would you give this person a cholesterol, a blood sugar, and a high blood pressure drug, knowing that that's going to decrease oxygen to the tissue? Oh, you're right, you got to give them a pain reliever. So that's going to decrease the body's ability to regenerate tissue. You're causing the body to be in a further stress state because they're chemically stressed. And if you're giving something to slow the blood pressure down, does that help oxygen the brain or slow it down? It slows it down. So then, altered gait leads to an unstable pelvis. And this is the key. This is why we're going to go over how to use a trochanter support and how vital it is. Because if you have somebody walking crooked, is that going to damage the pelvis? Anybody that's working on a knee, like if you got a physical therapist that's working on it, or an MD that wants to shoot it with some cortisone, which is psychotic, okay, are they going to check the other knee? Mm-mm. Why not? Because wouldn't it'd be under double the strain? Are they going to check the pelvis? Oh, that would make sense too. And so when you're looking at this, we have to look at the different structures. Now, there's no muscle that crosses the back half, okay, of that sacroiliac joint. So it's a perfect joint. You can see all the ligaments up there. It's amazing. And if anyone's curious to identify a male versus a female pelvis, male pelvis is like a martini glass, okay, and a female pelvis is like a margarita. Okay. I think it's cool. But now think of this. Okay, so you've got a knee problem. You're walking a little crooked. Your pelvis is unstable. If you start to destabilize the pelvis, that means the pelvic nerves aren't going to function correctly. Loss of bowel and bladder control. So that means if you're going to have a knee injury for decade after decade, or even year after year, or month after month, you're still going to be altering the function of that pelvis. So this means sexual dysfunction, loss of tone of the pelvic nerves. Okay, you're talking difficult menstrual cycles, bowel and bladder problems. I mean everything. And so you have to look at that pelvis, or the body is given symptoms for a reason. So forget bladder control, leg pain, foot pain. Okay, do you like the G-rated? Okay, I'm just saying, if you're looking for a male and female butt that isn't going to piss someone off, okay, Statue of David, baby. Okay, so I know. Okay, now, bunions. Bunions do not run in the family. Bunions do not run. Okay, I know, bad joke. Okay, but what bunions are, it's weak intrinsic muscles of the foot. So now a thinking person might say, well, where do those nerves come that supply the foot? They come out of the low back. So if we're seeing a foot flatten out and bend off to the side, we know that that's compromised nerve supply to that foot. Those nerves come out of the pelvis. So when you see this, that bunion formation, that isn't from wearing tight, funky shoes, okay? It's from compromised nerve supply to that foot. And in fact, with 3 sisters, and my mom actually wrote this book or started this book called A View from High-Heeled Shoes. Okay, honest to goodness. So every member of my family, wife, if I tell him to not wear high heels, I'll get killed. So you gals can wear high heels. I'll just show you in a couple of minutes the exercises you can do so you prevent the damage. Because when you're wearing high heels, do you feel pretty, tall? Yeah. So guys, when your girls are wearing high heels, yep, smile. Yeah, you bet. Dude, I'm with you. Yeah, it's okay. So, but we have to look at the biomechanics. So when you see a bunion on there, what are you looking at? You're looking at bowel and bladder problems. You're looking at all sorts of dysfunctions because it means that the pelvis isn't working correctly. And then you can even see this when you're walking behind someone. If they're walking in a good gait, great. If they're moving their pelvis one side and then the other, okay, you know that the pelvis is also damaged. Now, the blood flow. We know that the synovial membrane is full of a superfiltrated blood. However, this is really far from the heart, and blood tends to flow down with gravity. So the way you're designed is in the back of the calf muscle, we've got the gastrocnemius. Underneath that is a muscle called the soleus, and it's also called the soleus pump. So in order to have healthy biomechanics, we got to restore the blood supply, nerve supply, and also how the foot works. Because if that calf isn't working correctly, you're not going to be lifting the foot correctly, and that means you're going to be walking with your pelvis. So number one thing, this is hugely important. I have this extremely technical device called a 4x4. No, it's a medical device. Okay, because now I got to tell you, my wife's got size 4.5 shoe, which is like ridiculous. This is 3.5 inches high, and she can use it. Okay, just make sure when you're stretching that you're standing back further. You're also going to see that if you have teenagers, and this is just 3.5 inches high, what would that be in Canadian? Okay, 3.5 inches. You must be on the border. I'm looking for the northern ones that know the metric system. Okay, so when you're looking at this, you're going to also see kids with neurologic damage, people with neurologic damage, they're toe walkers, okay? And they're not going to be able to stretch their calf. And so this is a shocker and a wake-up call for a lot of parents to say, hey, look, that kid that's in speech therapy at 8, which is not normal, okay, let's find out if they have good gait, because that can indicate that there's a problem with the brain. And that would give us an idea to start healing that brain, and you could do it. But this is a good stretch and vital to stabilize the pelvis. Now, because it's going to stabilize the gait, because if the calf doesn't work right, you got decreased blood flow and you've got altered gait. This right here, I mean, the black areas are a leaky gut. So this person is being poisoned, but the white areas on either side of the sacroiliac joint, that's pelvic instability. So how do you check it? You got to squeeze the pelvis together. Okay, and literally, we will approximate the pelvis, which this is the pelvis. Okay, and we'll get there and we'll apply pressure on it. And it shouldn't feel better, because this joint, if it's unstable and you approximate it, you only got 2 things. If it hurts worse, that means that it's inflamed here and they still need the trochanter support or a way to support it. If it feels better, they still need a support. If it doesn't feel better or worse, then they don't need it. Okay, does that make sense? Okay, so now the trochanter support, this, we get it from Mayer Distributing, But all it is a belt that goes on, and it goes 1 inch below the pelvis, and then the other part tightens up. So it's a 2-pole support. This costs around $9. Okay, it's very, very inexpensive. But here's the key. You're probably only going to need it for about 4 or 5 weeks because the pelvis is perfect. That's right. You're really good design. You don't require a lot, but the pelvis has to be stabilized. Now, if you've had really long-term low back problems, really long-term biomechanics, you might need it for 6 months. If there's a scoliosis, you might need it for a year. But this, typically, you're looking at 4 or 5 weeks to a couple of months. Also, to check the pelvis if it's stable, you sit in a chair and open your legs up wide, just like Mom said not to do. Okay, but if it feels better, that means that the hips are approximating. The hips, the legs go out, and it squeezes this in. So you can also sit backwards like a cowgirl if you're doing office work, and that'll help stabilize it as well. So now we know sitting, when you're sitting on what's called the ischial tube, and that's the butt bone. And sitting increases the pressure on the L5-S1 disc, the disc at the bottom, 5 times normal. I mean, golf swing increases at 8 times normal. So sitting is damaging. So that's when we use a foam block. Now, this is very, very dense. It's hard to squeeze. You can also use a liter bottle of water. Okay, liter bottle of water from IKEA. Okay, we're talking just standard. And what this is going to be done, it's placed the bottom of the elbow is the bottom of where it goes, and it's placed just like this behind the spine, 20 minutes in, 10 minutes out. 20 minutes in, 10 minutes out. And what this is going to do, it's going to create a negative pressure to increase the curve of the low back. It's going to reposition the chest. And this is an exercise you're going to do. Now, if you have long-term disc injuries, this will be ridiculously uncomfortable. Then don't use it. Put it in for 5 minutes or 3 minutes and 5 minutes out. It may take a week or so to work up to the 20-minute mark, but it's absolutely essential to start to restore that curve, to restore the normal biomechanics. Now, let's think of this, okay, because we've already read that because of an abnormal force loading, that the meniscus starts to get damaged. So let's increase the force loading. Now, think of this. If you're walking, half of the time the leg is swinging in the air, half of the time it's getting compressed. Swinging, compression, swinging, compression. And what we have is we've got damage. So what if we put that under a negative force loading, just distracted the heck out of it, okay, and just dangled it? The key is with the weights, we're doing between 10 and 20 pounds. A guy like me, I'd do 20 pounds. Okay, a girl like you, 10 pounds. Okay, because it has to be enough to open the joint. But what you don't want to swing that knee higher, because you don't want to drive that patella into the knee joint because it's already damaged. So think of just a clock, just very, very little gentle. But you also want to move one leg up, one leg back. So it's very gentle. So this way, you're getting this cross-crawl activity so it gets both halves of the brain to fire correctly. So this way you get balance. Why? Because you've been walking funky for a while, and we want to correct the altered biomechanics, and this changes that proprioceptive firing. But think of this. You're creating a negative pressure, right? Is that going to increase the blood flow or increase the blood flow? Absolutely. I mean, it's just brilliant. Now, what if you're doing this leg swinging exercise and you put moist heat on the knee? You're increasing blood flow exponentially. Now you're straining the ligaments. Straining them is going to cause an inflammation. And the inflammation is how the body repairs. Now, if you've just had surgery, this would not be good, okay, to repair a ligament. So you got to, have this exercise directed by a qualified person that knows how to regenerate meniscus, because this is going to restore the biomechanics. It's going to create a negative pressure. It's going to cause blood flow to go there. I mean, it's brilliant. So think of this. When you get a damage on the meniscus, okay, and it's torn, people will come in and say, yeah, about 5 years ago, my doctor said my meniscus was torn. And I'll go, well, did it heal? And they'll look at me like I've lost my mind. Say, well, it's living tissue. Did you ever cut yourself? Well, yeah. Did it heal? Yeah. Okay, good. So all you got to do is understand that when you're creating negative pressure and when you're opening and closing that joint, you're approximating or getting more normal biomechanics to that, and that's going to approximate the tissue because the tissue is alive. If you bring it together, it heals. It heals. Now you're supposed to say, wow! And it's true. This stuff really works. Now we got to get patellar tracking. The kneecap, okay, or patella, is guided. And so what you're going to do, you've got the length of the D, you're going to hook that patella and pull it down from the outside to the in at an oblique angle. And you'll see, we're going to go over patella tracking later, but this is actually mainly for doctors to identify, because the quadricep, the muscle that holds that patella, that actually lifts the leg and allows the leg to go in extension, that quadricep has two main things that guide the action of that patella. And the vastus medialis, vastus lateralis. And so if you take the lateral one, the one on the outside, hook that kneecap and pull it down and across towards almost the ankle, if that causes discomfort, and I mean considerable discomfort, then you might have a weak vastus lateralis. If you grab the kneecap on the inside and pull it down at an oblique angle, kind of down around to the ankle area, that force loading, and we're talking just like a 1 to 2 pounds of pressure. If that causes discomfort, then the vastus medialis is too weak. Okay, and you can see going downstairs or down a hill, if that's uncomfortable, it's generally vastus medialis. Going uphill or upstairs, it could be vastus lateralis. But all this has to be confirmed with that patellar tracking test. And then you're going to swing your legs, but this time, different than with the ankle weights, you're going to actually kick your legs up all the way. Except you're going to turn your foot in for vastus lateralis, out for vastus medialis. So think of Charlie Chaplin for vastus medialis, Jerry Lewis for, vastus lateralis. Am I the only one that knows Charlie Chaplin and Jerry Lewis? There's got to be an actor now walking pigeon-toed or out to the side. I got to get more with it. Okay, so California Jam, Bergman 20, Extreme Health Academy, Bergman 14, and get on the cruise. Get on the cruise, 12 hours of continuing ed, but just to hang out is going to be fun. Next week, we're going to talk about hiatal hernias, and then it's going to be inflammatory bowel diseases. We're going to go over all the anatomy and physiology so that we can learn how to take care of our bodies. And all our vaccine stuff, we're going to have links on this stuff that's going to go over to BitChute. So that way, hopefully, we can have this platform for a little while longer, and that way we can have two groups, the anatomy, physiology, and the neurotoxic stuff. Thank you very much. Good job.